Good morning. I'd like to welcome everyone to the first MDT for the academic meetings of 2025. So this is very new to all of us, and I'd like to thank Dr. Zamparini for introducing this whole MDT concept. We've got about three, if I'm not, am I right? Three or four? Three or four for this, I think for this year. So the first one is hosted by the Division of Endocrinology and Oncology, and I'm sure you guys looked at the topic and are thinking, did we get this wrong? Breast cancer and endocrine. But we've got two amazing speakers today who are both going to unpack the bidirectional relationship between cancer and metabolic diseases. And I think they're also going to go through a bit of the therapeutic and prognostic implications. But I think the reason these MDTs are important, and I hope that the future ones are also going to sort of inspire us to work together as a team, is that I think we're all still stuck in the silo effect. And I think we still all like to work with in our own divisions. And maybe occasionally we'll have an MDT with the surgeons or with the other disciplines, but not actually with each other. And I think by speaking to each other and actually working together, we'll be able to improve patient outcomes. So I hand it over to Dr. Adams, a consultant in my department. And yeah, enjoy.
So there are many intersections between endocrine and oncology. We won't be able to speak about everything, but I'll be focusing on the common endocrine etiologies and perspectives for cancer. We'll also touch on the endocrine therapies for cancer and maybe discuss some of the endocrine side effects of cancer therapies. So the hypothesis is that the hormones that control normal target organs can also create the proper conditions for carcinogenesis. There are many pathogenetic mechanisms that are associated with malignancy, and I'll be unpacking some of the epidemiology and clinical implications of these. I'll start with the case. This is a 41-year-old female housewife, mother of two. She's known with hypertension and diabetes, and she's been well controlled at her primary health care for the last 5 years. She comes in, she's had a lump in her left breast that grew rapidly over the last 6 months, and she was seen at the breast unit with the final workup showing luminal hormone receptor positive but 2 negative breast cancer. This is just a reminder of what the cell cycle looks like. So remember that it's a series of stages where actively dividing cells give genetic material to daughter cells. So it's quite crucial during the cell cycle for material to not have any mistakes that might be conferred to daughter cells. So the gap phases are periods of breast core growth, and you've got this S phase, which is where new DNA is synthesized. The mitotic phase or the M phase is tightly regulated by checkpoints to make sure that there aren't any DNA mutations that will be conferred to daughter cells. So normally what happens is growth factors enhance the functioning of the cell cycle. If you have a high number of growth factors, they might cause rapid progression through the cell cycle and leaving much less time for DNA repair. This is an example of what a growth factor dependent intracellular signaling looks like. You can see the cell membrane 2 receptors there. This is an example of what the IGF-1 receptor is. The triangle on the top is the ligand that binds to the cell receptor. After binding, these 2 receptors they dimerize and they result in phosphorylation and autoactivation of, let's say, a mitogenic pathway that starts with autoactivation of tyrosine kinase. I've highlighted some of these factors because they're all mitogenic and result in cell growth. RAS, LAF, MEK, MAPK, PI3K, AKT, as well as mTOR. IGF-1 stimulates these processes and results in cell growth, as well as differentiation, as well as inhibition of apoptosis. So it's important to remember that even if a cell is programmed for cell death, if it's exposed to high levels of IGF-1, apoptosis will be inhibited, and this cell might then survive with the mutation. mTOR is important as well because it results in utilization of glucose in the cell, which then will increase growth of the cell. It's important because it's a therapeutic target. For example, if everolimus will work by inhibiting mTOR, this will mean that the patient could have dysglycemia, hyperglycemia, even diabetes, as well as dyslipidemia. They're not able to utilize glucose. So some of the endocrine cancer therapies also cause metabolic disease. This is an example of signaling through a steroid receptor complex. So this is different. The hormone goes through the membrane. It binds to the cytoplasm. The receptor is located. And after binding, it then transverses the nuclear membrane and binds directly to response elements on DNA. So this means that any molecules that are able to bind to hormone or steroid receptors at the nuclear level will change DNA sequences, and this could also lead to carcinogenesis. So examples of steroid receptor mechanisms would be the estrogen receptor, the androgen receptor, as well as glucocorticoid receptors. So these are some of the common known growth factors. We've spoken about IGF-1. Generally, when we talk about growth hormone, we mean it's IGF-1 mediated effects, as well as the epidermal growth factor and FGF, which is important for muscle growth. So where does insulin fit in? Insulin's famous for regulating carbohydrate metabolism, but it's also a very potent growth factor. Insulin-like growth factor, IGF-1, is structurally similar to insulin. So insulin stimulates the IGF-1 receptor. In real life, we have evidence of this because diabetic mothers their kids have fetal macrosomia. Patients who have uncontrolled diabetes lose weight and they regain their weight with insulin treatment. So what will happen is if somebody has got insulin resistance and high levels of insulin, that will stimulate the IGF-1 receptor and leads to growth as well. This is an example of the HPG axis. So at the hypothalamic level, you've got gonadotropin-releasing hormone that stimulates FSH and LH to stimulate the ovary. So in the ovary, you're going to get folliculogenesis, so growth of the follicles every month. These follicles then synthesize sex steroids, which is testosterone and estrogen. This conversion of testosterone to estrogen is done by aromatase. And so aromatase is the hormone that converts or synthesizes estrogen from androgens. Aromatase is also located in peripheral tissues like adipocytes. So patients have got a high number of, especially visceral adipose tissue, have higher numbers of aromatase. So they have higher estrogen levels. Eventually, estradiol stimulates the estrogen receptor, and we know in women it's responsible for maintaining the reproductive system, so the ovaries, the breast, and the uterus. Estrogen receptors are found in many other tissues, especially bone, cardiovascular, and the neurological system. So not to forget again, IGF-1 and epidermal growth factor. The ovary has high levels of IGF-1 receptors. Remember, it's a tissue that grows every month and makes new follicles. So again, patients with high insulin levels could get polycystic ovaries from stimulation of the IGF-1 receptors. Despite the IGF-1 and the estrogen receptor not being similar at all, there is crosstalk between the two. So again, patients with high IGF-1 levels have crosstalk with the estrogen receptor. So do growth factors directly lead to malignant transformation? Perfect example to discuss would be acromegaly. Patients with acromegaly have growth hormone excess. They've got high IGF-1 levels. We know that it's got a trophic effect and it leads to tissue growth. But do they have a higher risk of malignancy? At the moment, a lot of studies have shown controversial and contradicting results. We know for sure that patients with acromegaly have a higher risk of getting colonic polyps. But the patients who get polyps are the patients who also have higher skin tags. They are patients who are above the age of 50 that are male. So there are probably other risk factors as well that contribute to carcinogenesis outside of just the growth factor. As we've said before, the growth factor doesn't directly result in malignancy, but it will cause less time for DNA repair in a rapidly growing cell. So at the moment, I'd say data collected over the last 60 years have shown that the effect of prolonged growth hormone excess in carcinogenesis is marginally increased and its clinical impact is modest. So what happens in somebody who's got a high number of adipose tissue, especially visceral adipose tissue? This person will have high aromatase levels and high levels of estradiol. It's been shown that patients with overweight and obesity have a twofold increase in their estradiol levels. Obesity and overweight is associated with 40% of cancers in the USA, and it's been associated at the moment with at least 13 different types of cancers. So we maybe forget that adipose tissue is an organ in itself. So it's hormonally active, it makes aromatase. It also is it's also inflammatory. So because it's inflammatory as well, it secretes a lot of fatty acids, which then impair insulin receptor signaling. So you get insulin resistant and you get hyperinsulinemic with obesity. These high insulin levels then further cause either stimulation of the ovary to make more androgens and estrogen, increase the estradiol levels. And on top of that, because they stimulate the IGF-1 receptor, they'll also cause growth. So the implication of this will mean an increased risk of breast cancer, as well as endometrial and ovarian cancers, as well as the other hormone receptor positive cancers. So patients with polycystic ovary syndrome have a combination of all of these factors. They're associated with a 50% chance of being obese. They have hyperandrogenism from their polycystic ovaries, as well as high estrogen levels. On top of that, because of failing to ovulate, they have all these many cysts that didn't ever ovulate and then regress. These cysts remain hormonally active, secreting high levels of androgens. And on top of that, because they amenorrheic, they still have an endometrial lining that doesn't shed every month. So their risk of getting endometrial cancer is very high. Another important concept to note are called endocrine disrupting chemicals. So these are compounds we find in consumer products we use in everyday life. They contribute to malignancy and endocrine disease. So as I said, a lot of this is based on the receptor signaling. If you've got a compound that binds to the estrogen receptor or to other steroid hormone receptors, as well as nuclear transcriptional regulators, they might then confer selective growth for malignant cells. We're exposed in many routes, and this is just an example of a heat map showing the 10 most common endocrine disrupting chemicals and the type of associations they have. So BPA and food packaging, as well as plastics, are highly associated with getting obesity. So we live in an obesogenic environment. Inhaling exhaust fumes and combustion of materials increases benzopyrene levels, which is associated again with carcinoma. So a lot of the environmental exposures we have are already carcinogenic and obesogenic. So in South Africa, the global prevalence of obesity and diabetes has increased astronomically, and it also mirrors the increase in cancer rates. In South Africa, the prevalence of adults living with obesity has rose by 38% over the last 20 years, and women are much more affected by than men, more than double that of men. This is an example of the top 10 conditions that are attributed to obesity. People are dying from hypertension, diabetes, and cancers. So the global incidence and mortality for female breast cancers here is noted in 85 countries. South Africa still makes the top 10 in the incidence of breast cancer, 15.4 per 100,000. The mortality rate from breast cancer in Southern Africa is 15.7. And if you look at the rest of Africa, our mortality rates from cancer mirror first world countries or more developed countries. So the risk of dying from breast cancer in South Africa is still the same as first world countries. Is obesity associated with survival outcomes in patients with cancer? This systematic review looked at over 6 million participants, and they evaluated the association with the overall survival, the cancer-specific survival, and the disease-free progression of patients living with obesity and cancer. Obesity was associated with a reduced overall survival from cancer, a reduced cancer-specific survival, as well as an increased risk of recurrence of cancer, especially breast, colon, uterus. There are actually a few cancers that do better in obese patients, and it's been noted to be lung, renal, and melanoma. We call it the obesity paradox. Most patients with cancer, as we explained, have a lot of reasons why they might do worse with either getting diagnosed, getting treated, getting investigated, and all the other comorbidities they might have that make their treatment journey complicated. But you might then assume that having a higher body mass might mean you've got higher muscle mass as well. So some cancers do a little bit better in obese patients. That being said, anybody who's at the extremes will still do worse. So someone with the body mass index of above 35 will have poorer outcomes, even if they had lung or liver. So does losing weight improve your risk of cancer? So weight loss after bariatric surgery does lower the risk of incident cancer. This was a retrospective matched cohort of patients who had undergone bariatric surgery. So 18,000 patients who had undergone bariatric surgery were matched to 40,000 patients who hadn't undergone bariatric surgery. They were followed up over a 10-year period. So the outcomes were weight loss at 1 year as well as the incident cancer at 10-year follow-up. The patients who had undergone bariatric surgery had average weight loss of 27% compared to those who hadn't. There were 1,196 incident cancers in this group of patients, and they found on the left you can see the Kaplan-Meier curve that patients who lost the most weight with weight loss of above 30% had the best survival, cancer-free survival. And this risk was even better of not having cancer at every 10% weight loss that the patient had. They didn't find an independent effect of the bariatric surgery itself. All of this was just from losing weight. So my patient, she says when I saw her recently referred after her breast cancer diagnosis, said the first time a healthcare professional ever mentioned her weight to her was when she was sitting with the oncologist and getting counseled about her diagnosis. And she was being told that she can't have surgery because she's a high surgical risk, which was potentially curative. She needs to get chemotherapy at higher doses than usual because of her weight. And if she's able to lose weight, perhaps in a few months, she can get surgery. So this is the moment she was coming to see me. She was also told that she might be on glucocorticoids during her surgery, and that's going to hamper her weight loss efforts a lot. So I've borrowed this quote from the makers of the Big O. Obesity is the first thing you see. Don't make it the last thing you treat. So what's happening, because obesity is a global pandemic. It's a pandemic, especially in Africa and Southern Africa, because we still have all the diseases of third world countries relating to infectious diseases. We also have the burden of non-communicable diseases. There is actually a document made by the government called the Strategy for the Prevention and Management of Obesity in South Africa. It's one of the National Development Programs for 2030. They're trying to approach obesity in all aspects of life, not just as an individual level. We know that we have an obesogenic environment, so it would mean paying attention to, well, we have a sugar tax, but maybe getting food out of the junk food out of the aisles at the shopping centers, at the checkout aisles. It will mean having safer outdoor places so that we decrease the sedentary lifestyle. There's a lot of interventions done at a public health level that would be needed. Obviously, at an individual level, it's our duty then to discuss this with patients. Weight bias, stigma, and discrimination still remain a big hurdle to overcome. It's not appropriate anymore to say eat less and move more. Obesity is much more complex than that. We think it's a biological disease. So the South African Metabolic Medicine and Surgery Society is currently working on, say, obesity guidelines. So they're going to endorse obesity as a disease. This will help funders then actually reimburse patients for obesity-related treatments. The economic impact of obesity in SA is estimated to be above 700 billion if you look at both the direct and the indirect economic impact of obesity. Patients with obesity can have obstructive sleep apnea. They miss a lot of days at work. There's so much morbidity that comes from having obesity. So again, we try to reframe how we speak about obesity. It's a person living with obesity. We want to ask the patient permission to discuss it. We want to share information in a sensitive way and share science with them. Sometimes we think obesity treatments are expensive, but patients are very invested in their health already. They buy nutraceuticals, they have a gym subscription, they add in minerals to their water. There's a lot of things that they're doing. I had a patient come wanting the big O, and she said that it costs less than a personal trainer. There is probably money that's available to manage obesity better. We just have to start having the conversations with patients. So this talk won't cover managing obesity, but I'm just bringing your attention to some online resources. A couple of years ago, we did a review article on the management for obesity in South Africa. The only updates now would be the arrival of GLP-GIP molecule, tirzepatide, which is on shelf in South Africa, as well as the higher concentration semaglutide molecule, which should also be launching soon. We also did an obesity masterclass that covered the spectrum of treatment from lifestyle to medical management to endoscopic minimally invasive approaches as well as bariatric surgery. Thanks, Dr. Evans.
So I think for the interest of time, we're going to do things a little differently today. We're going to introduce our next speaker. So I'm calling on my co-chair, Dr. Mayet, who will then introduce Prof. Demetriou, and then we will take the questions at the end of the meeting.
Yeah, thanks, Constance. I think with obesity and a lot of these endocrine disorders, I think we're more so inclined to think cardiovascular, renal. Nobody really thinks about malignancy and the risk related to it. But yeah, there's some interesting facts there. Next up, I'd like to introduce the boss lady, head of our department in medical oncology, chairperson of SAOC, and overall just a fantastic person. Georgia, who's going to speak about breast cancer as being an endocrine disorder.
So it's a very kind introduction. I just need to find where my talk is. I'm gonna. Oh, did you add it on? There we go. Thank you. So yeah, so to my very gracious 2IC, Joe Mai, thank you for the kind introduction and for running the department while I'm on leave. So I'm very, very grateful. So I'm going to go through breast cancer as an endocrine disorder. And I think no oncology talk is complete without a few stats. So globally, breast cancer is the most common cancer. And that's not just looking at women, that's overall across the sexes. We say breast cancer is the most common cancer globally. About 2.3 million new cases diagnosed in 2020, of which about 685,000 cancer deaths attributed to breast cancer. And there's quite a bit of a variation between some of the more developed and developing countries. And as we see economic transition, we see that the risk of breast cancer does in fact go up, but the actual mortality in more developed countries goes down. But there's a disproportionate share in low and middle income countries in terms of deaths. I would like your stats, Constance, that we're probably keeping up with what the first world, or not first world, but upper middle income countries are doing in terms of mortality. But I think that might be due to the stats collection to a certain degree, and also down to the fact that a lot of the newer agents are available in the private sector. We hope to see them at some point in the state structures as well. And this is just a nice sort of diagrammatic representation of the burden of breast cancer in terms of incidence in pink, but not causing the most amount of deaths. Certainly lung cancer, colorectal cancer, and hepatocellular carcinoma outstrip breast cancer. So the risk factors, Constance, you've touched on in terms of breast cancer to a certain degree and cancer overall, but just coming down onto breast cancer, certainly increasing age is a risk factor. That's not really modifiable. If anything, we want people to live longer. I mean, that's the objective. So as we go over time, postmenopausal women do have a high risk. Obesity, as you've so rightly mentioned, but that is one of the modifiable risk factors. Alcohol, again, a modifiable risk factor. We can drink less. A family history of breast cancer, nothing you can do about that. If that's what you're born into, that's what you're born into. A history of radiation exposure, and here I'm talking really about patients who have maybe had breast tissue radiation as sort of pubertal age, your Hodgkin's lymphomas where maybe they've had mantle radiation. So that does increase risk of breast cancer quite significantly. And then reproductive history. If we look at the data, if your menstrual cycles start sort of early, you have a high risk of breast cancer. And for every 2 years that your onset of menses is delayed, there's about a 10% reduction in the risk of breast cancer. If we look at the onset of menopause, for every year that your menopause is delayed, and the average age they say is about 49, 50, then there's about a 3% increase in your risk of breast cancer. Again, those aren't necessarily modifiable risk factors. What is possibly a little bit modifiable is your age of first pregnancy, and a first pregnancy after the age of 35 potentially also conveys a higher risk. Tobacco use, interestingly enough, is there, and there's also postmenopausal hormone therapy, as well as dense breast tissue and inherited risk of breast cancer. Those we really can't modify. So I'm also going to give a case study. This is Mrs. NR. She's a 36-year-old female. She's paranaught gravida naught. She was actually with her endocrinologist, and she reported feeling a breast lump. And she was there for her follow-up because she has got various medical conditions. So there really is intersection between oncology and endocrinology, and I think we need to just be aware of where we intersect. So this patient had about a 12 by 14 millimeter solid lobulated lesion on the left breast. It was a BI-RADS 5 high-risk lesion, and they saw 2 enlarged lymph nodes on the mammogram she was referred for. An MRI was subsequently done, which saw a slightly larger lesion, and there was 1 suspicious lymph node. Patient went on to have a biopsy, and it was hormone receptor positive. It was dropping off its PR receptor positivity. It was, in fact, HER2 positive as well, and the patient had a Ki67 of 40%. A V marker was placed, and FNA was done of the lymph node. It was negative. However, it could be sampling error and could be discordant, but it was noted. There were no overt metastatic lesions. So what in her history makes her at risk of potentially getting breast cancer? Well, she was insulin resistant. She had a raised cholesterol, and she had polycystic ovary, and she was on metformin, atorvastatin, levothyroxine, and losartan. The next risk factor, I think that's a biggie as well. She had a weight of 83 kilograms, a body surface area of 1.8, and a BMI of over 30. She had a normal echo, and then she went on to get 6 cycles of chemotherapy with trastuzumab and pertuzumab HER2 blockade. And at surgery, we were very happy to see that she had a complete pathological response with no evidence of disease. She's about to start her radiation. She will continue her HER2 blockade, and she will probably start hormonal therapy post-radiation. She tells me that she is having lots and lots of hot flashes, and she no longer has menses. Her menstrual cycle was very intermittent, but now that's totally nothing there to be seen. So in terms of polycystic ovary syndrome, research does say there's potentially a link between polycystic ovary syndrome and breast cancer, but in fact, the results are sort of inconsistent. Initial studies indicate that there's a possible increase in breast cancer mortality amongst patients with polycystic ovary, but a systematic review by Chitton et al. Did not find a significant association. And these results imply that potentially it's not necessarily polycystic ovary alone that confers the risk to breast cancer, but it's the confounding factors of hyperinsulinemia, obesity, which are both prevalent in these patients. And there's going to be a bit of overlap, not only in the patients we see, Constance, but probably the data we present. But polycystic ovary independently also does give you some increase in postmenopausal, and that could be the insulin's role in tumor growth. Insulin resistant, present in about 65 to 70% of women with polycystic ovary, and it disrupts that whole axis of hypothalamic, pituitary, and ovarian axis, and elevates luteinizing hormone, and it also elevates the androgens, which interfere with normal follicular maturation. And the higher androgen levels in postmenopausal women are also linked to higher susceptibility to breast cancer, and its association mediated through androgens serving as your precursors to estrogen, which promotes breast cell proliferation. Also, type 2 diabetes and type 1, they both associate with increased breast cancer link, but probably type 2 driven mostly by rising adolescent obesity. And it's projected that in 2040, we'll have maybe 642 million people globally who have obesity. Diabetic women fare worse in terms of survival. Some of them are actually diagnosed at a later stage, experience poorer survival compared to non-diabetic women. And in a meta-analysis, it indicates about 20 to 30% increase in the risk of breast cancer in diabetic women. The pathway, I think you've gone through quite nicely, and hyperinsulinemia and insulin-like growth factor are tumorigenic and actually promote cell proliferation and inhibit apoptosis in breast tissue. And as you so rightly said, most of this key pathway in signaling is the PI3 kinase mTOR AKT pathway, as well as the RAS, RAF, and MEK pathways, which are critical for growth and metastases. This is just a different view of the pathway to what Constance presented, but here I have included a few things. And if we can see that the PI3 kinase, at the top there, we've got PI3 kinase inhibitors. So where there's a problem, there's a drug that usually is found to try and target it. So for your PI3 kinase inhibitors, we've got alpelisib, which is registered in South Africa, and inavolisib, which is not yet registered in South Africa. For your AKT, we've got an AKT inhibitor, capivasertib, which is going to be launched probably in the next 3 months by AstraZeneca. Then in your mTOR inhibitor, there's everolimus, which we've actually had for probably about probably close on 20 years now. And everolimus targets the mTOR, but I haven't really put the drugs in on the estrogen receptor pathway. Right at the top is your good old stock tamoxifen, which would go into your estrogen receptor pathway. And then further down, you also have your aromatase inhibitors. And the reason I didn't put them there is because they're a little bit old hat. They've been around for over 50 years, and they definitely are the mainstay of the treatment. And any patient treated in the adjuvant setting with hormone receptor positive breast cancer would either get tamoxifen or an aromatase inhibitor. But then the newer agents really come into the fore when we start talking metastatic disease. So in terms of SOLAR-1, it was a phase 3 randomized placebo-controlled trial, and they wanted to evaluate the role of alpelisib, which is an oral inhibitor of phosphatidylinosytide 3 kinase alpha. And it was given in combination with fulvestrant, which is a injectable selective estrogen receptor modulator. And the study was run in postmenopausal men and women who'd previously been treated with an aromatase inhibitor. And in the PI3 kinase mutant cohort, alpelisib provided a progression-free survival benefit of 11.0 months versus 5.7 months. There was a hazard ratio for progression or death of 0.65 and a not too wide confidence interval for this study. The median overall survival was 39.3 months for alpelisib and fulvestrant and 31.4 months for placebo. Just remembering, though, that overall survival can be impacted by subsequent treatments outside of the study as well. So the toxicity, though, of this PI3 kinase inhibitor pathway, as Constance has alluded to, definitely does reduce risk of death, reduce progression-free survival, but does unfortunately have hyperglycemia, which almost seems a little bit of a dichotomy, and you're trying to knock the pathway that's creating trouble, but if you're actually pushing up the glucose. Rash, and also quite a bit of gastrointestinal toxicity, nausea, vomiting, loss of appetite, mucositis, diarrhea, and fatigue. So there was a lot of patients who actually dropped off the study. 25% of patients discontinued, and there were 70 interruptions in treatment requiring dose interruption. So I don't find it an easy drug to use, but certainly we do have it as another step in the armamentarium for patients who tolerate, and you have to watch their sugars very carefully. And often they need to be referred for management of their insulin, of their hyperglycemia. Just as a note, though, to use PI3 kinase inhibitors, you have to demonstrate a PI3 kinase mutation in the tumor. So the dogma is that if a patient has got metastatic breast cancer, at progression, you want to biopsy the metastases. And obviously, you need to have an accessible site. But if you can demonstrate PI3 kinase, that then becomes your second-line hormonal blockade in the pathway. Of note, you can also biopsy bone sometimes, even with decalcification on next-generation sequencing, we are able to identify the PI3 kinase mutation. The next one is the AKT agent capivasertib. And this was looked at in the Capitello 291 study. And here they looked at patients, again, it was postmenopausal because they wanted to use fulvestrant, which needs to be, and the patients need to be postmenopausal for. Patients were usually quite shortly progressing after they'd been on an aromatase inhibitor. They could have had previous CDK4/6 inhibitor. And these patients basically were randomized to capivasertib plus fulvestrant versus fulvestrant on its own. And if we look at the overall population, there was a benefit with a hazard ratio of 0.74 for overall survival in the overall population. But where there was a PI3 kinase AKT-P10 alteration, the hazard ratio was 0.69. So not really a big difference. So for capivasertib, you don't necessarily need to demonstrate a mutation in the pathway. The whole population did benefit. Now, the Bolero-2 study was actually the first of this pathway, and the data was presented at ESMO in 2008. And it really was quite a staggering study in the sense that we had a hazard ratio of 0.45 for patients for progression-free survival. So, I mean, just to put that into, that's a 55% reduction in progression of cancer. And this was in a heavily pretreated population. And from that point of view, patients could have been given a non-steroidal aromatase inhibitor in the past because the study looked at everolimus with a steroidal aromatase inhibitor, exemestane. It also does work in patients who harbor ESR1 mutations, which tend to be mutations that occur with exposure to aromatase inhibitors, and that is the non-steroidal component, which is why the fulvestrant, exemestane, and tamoxifen can also be combined with everolimus. Of note, this was the first one of this pathway and also the first one to demonstrate hyperglycemia. Also, in pancreatic neuroendocrine tumors, everolimus is also registered, and it's of particular use there in your patients with insulinomas, because your patients with insulinomas tend to be dropping their sugars all over the place. So it's kind of novel to be able to treat the cancer and shrink the cancer, but also be pushing up their sugars and reducing hypoglycemic events. So it sometimes is a good side effect to have. And in terms of patients with visceral disease, you can see these curves beautifully split in terms of the hazard ratio for event of a progression 0.47 if you have visceral disease, much better if you have no visceral disease, and the hazard ratio is 0.41. And then bone-only metastases, a hazard ratio of 0.33. So that's a phenomenal 67% reduction in the chance of patients progressing. So do the diabetic medications that we have available in these diabetic patients potentially also reduce risk of breast cancer? And certainly the risk can vary. Metformin has demonstrated protective effects, reducing breast cancer incidence and improving survival in specific subtypes, particularly HER2 positive patients appear to have a benefit from the use of metformin. In contrast, insulin and sulfonylureas actually are associated with an increased risk of breast cancer recurrence where a patient has already had a cancer, and sometimes a worse survival. However, it does reduce the incidence in terms of the first occurrence, but once you're using insulin, it seems to have patients get a faster progression. So a little bit of a contradiction in terms, but it might be because of the weight gain, that when they aren't well controlled, they're losing the weight and then they suddenly start gaining the weight. GLP-1 inhibitors, receptor agonists, and the SGLT2s, they don't seem to increase the risk for certain at all, and in fact, they potentially reduce overall risk of breast cancer, but you need to look at your patient and what potential drug might assist them. Constance has gone over obesity quite well, but since 1990, a doubling in breast cancer risk because of obesity. And I think that is quite a clear association. Meta-analysis revealed 35% increase in breast cancer-specific mortality and a 41% rise in all-case mortality amongst obese patients. And also triple-negative breast cancer. It does also seem to reduce the overall survival and shorten disease-free survival. And if you have a high BMI, it does tend to be linked to hormone receptor positive tumors. But we do also tend to find that they have larger tumors at presentation and more frequent lymph node involvement. In a Danish breast cancer cohort of about 13,000 patients of postmenopausal and hormone receptor positive breast cancer, overweight and obese women exhibited significantly poorer survival outcomes with an increased likelihood of recurrence. And that was just a duplication in that last one. So while you're busy exercising, even if it is just your arm, just remember some of the stuff we're putting in our food is going to be the problem. So menopausal patients tend to have lots of menopausal symptoms, and hormone replacement or menopausal hormonal therapy really took a bit of a knock after the publication of the Heart and Estrogen Progestin Replacement Study in 1998 and the Women's Health Initiative in 2002. And it really marked a pivotal point in terms of rethinking hormone replacement because of breast cancer and cardiovascular risks. So what do we know about hormone replacement? In terms of mortality, they looked at about 27,000 women aged between 50 and 79 for over 2 decades. And those patients receiving conjugated equine estrogen alone, primarily in those who previously had a hysterectomy, exhibited a significantly lower risk of breast cancer incidence with a hazard ratio of 0.78 and mortality with a hazard ratio of 0.6. And that was compared to placebo. However, women on conjugated equine estrogen plus medroxyprogesterone acetate actually showed a slightly higher risk of breast cancer incidence. And there's no significant difference in mortality for these patients. So I think what it says is look at your patient, look at their history. Certainly for a patient who's got an intact uterus, you can't use estrogen alone. But in the Million Women study, the postmenopausal woman also showed that it did increase risk and breast cancer mortality. But it really was important out of this study that the longer you use the hormone replacement therapy, the higher the risk. So past users with over 5 years also had an elevated risk. So I think the rule really is try and use it if you're going to use it early on in menopause, and try not to use it for longer than you need to. So as long as you need to try and control symptoms, but then do think certainly at 5 years of taking it away. So what are the recommendations in terms of hormone replacement therapy? It's definitely contraindicated in hormone-dependent neoplasm. So if you've got a patient who's got a hormone receptor positive breast cancer, or in fact an endometrial cancer, which is estrogen receptor positive, you do not want to give HRT. And also if they've got a high coronary or cerebrovascular risk, do think twice. It is recommended for symptomatic menopausal women without contraindications, but you must initiate within 10 years of menopause ideally, or before the age of 60. Otherwise, you potentially are not going to confer benefit. And in patients who have got premature ovarian failure, you should use it until the age of 50, but then consider withdrawing. And in terms of the risk of breast cancer from hormonal replacement, it is relatively low. It's about 1 per 1,000 additional cases per year, but you don't want the whole patient to be that one patient. So just always think as short as possible, start as early as you can if you need to, and before the age of 60, otherwise do not initiate. And combined estrogen and progesterone is not recommended for the primary prevention of chronic disorders. If you're worried about bone density, think about weight-bearing exercise, vitamin D, and there are bisphosphonates as well. So always think twice and tailor your HRT to your patient. So acromegaly, here we've got pituitary tumor leading to raised growth hormone, but also insulin-like growth factor. We do find that the elevated risks do increase risk of breast cancer, about 28% increased risk of breast cancer, and a more pronounced risk in hormone receptor positive patients, about 38%. Tamoxifen is a selective estrogen receptor modulator, and it's shown to decrease insulin-like growth factor levels in breast cancer patients. So it doesn't extend its benefit, though, to growth hormone. So even though you're impacting part of that pathway, you're not impacting both sides. So it does still convey the risk in acromegaly. Hyperprolactinemia. There was a large-scale prospective study looking at prolactin levels measured at study entry in postmenopausal women, and it's positively associated with breast cancer risk. Women with a baseline prolactin level at the highest quartile were 2 times more likely to develop breast cancer than women with a prolactin level at the lowest quartile. And the relationship is independent of other hormones. And it suggests that the high prolactin levels are associated with the increased risk, especially postmenopausally. Other things to always think about with increased risk, multiple endocrine neoplasias, the MEN1 group. There was a Dutch study that highlighted that women with MEN1 are 2 to 3 times at higher risk of developing breast cancer than general population. MEN2, where there's also a RET mutation, correlates with endocrine resistance in breast cancer. So those patients may not respond as well as we want to endocrine therapies. And in MEN4, CDKN1B plays a pivotal role in the pathogenesis of luminal breast cancer, so your hormone receptor positive. There is a bit of a link with von Hippel-Lindau syndrome, and probably more because these patients are always at high risk of developing pheochromocytomas and paragangliomas. And then also congenital adrenal hyperplasia has got a link. So this is going to be one of my last slides, second to last. And really, we need to think about screening. So before the patients arrive at me, somebody has to have picked up the cancer or at least been aware of the cancer or their risk of cancer. So I think that's where I say we need to all work together. And if we look, you've got to tailor your screening to your patient's risk. For patients with MEN1, we would say that these patients, because of their 2 to 3 times higher risk, should be screened every 2 years at least. And MRI screening from the age of 40 can be advocated for because they do tend to have denser breast tissue. So you actually aren't going to necessarily see subtle lesions on a mammogram. Also for women with diabetes and obesity, conditions increase patients' postmenopausal breast cancer risk. So these patients also need to be screened at least every 2 years. And you might also need to think about increasing the frequency to annually for patients with very high BMIs and uncontrolled metabolic factors. Patients with polycystic ovary, the same holds, probably every 2 years is okay. If you've got very dense breast tissue, rather think about MRIs, but that would need to go through a special motivation. And for patients who are on hormone replacement therapy, those who are on estrogen only probably have a decreased risk, so you don't need to worry about them as much and stick to the guidelines in terms of the general population. But for those who are on combined estrogen and progesterone therapies, especially with more than 5 years of use, you need to put them in a high-risk annual screening program. Patients with hyperprolactinemia, you need to closely monitor them also probably every 2 years is reasonable. And then for acromegaly and von Hippel-Lindau, you need to risk stratify and probably think about every 2 years as well. So there's an intersection of care between endocrinology and physician clinics and oncology, and the patients are primarily managed within the endocrine physician space, where really we have a reason to consider pausing and looking at patients' potential breast cancer risk, endocrine treatment optimization, and especially screening, because we can impact disease and reduce risk of breast cancer, but if we're not going to be doing that, early detection does also improve survival. So just keep thinking about your patients and their risk. Thank you.